Pulp therapy for primary teeth can be divided into three different modes of treatment. These are the indirect pulp cap, the formocreosol pulpotomy, and the partial or total pulpotomy. This series of videotapes will describe the indications, techniques, and results of these treatments. This particular tape will discuss the indirect pulp cap. This slide is a diagrammatic of a normal primary tooth. The tooth has been subjected to no traumatic injuries nor any attack by dental caries and should contain a normal dental pulp. Normal pulp contains both defensive cells such as leukocytes or macrophages and reparative cells, undifferentiated mesenchymal cells. Normal dental pulp has a defensive capability to ward off an inflammatory process and then repair any damage that has occurred. I would like this time to present a concept that the pedodontics feels is enough to be maintained the rest of your professional practice years. At that moment when the dental caries attack reaches the dentino-enamel junction, it involves the end filaments of the tomes fibers, and consequently those now become involved in the inflammatory process. The degree of inflammation is not known, but it does occur because the odontoblast is a unit of tissue and approximately 60% of its cellular content lies within the dentin itself rather than in the pulp. When caries has penetrated to the dentino-enamel junction, the dental pulp will respond and react to the inflammation that is going on in the extensions of the odontoblasts into the pulpal tissue. At some point of penetration from the dentino-enamel junction to an overt pulpal exposure, the inflammatory process in the dental pulp becomes irreversible. It would be very handy for us as dentists to be able to locate this point of no return in dental caries penetration by means of a radiograph. However, this is impossible without a microscopic view, but there is a clinical technique available where we may utilize the pulp's ability to heal itself. This is the indirect pulp cap. This technique is explained in the next few slides. Clinically, this child has presented with teeth that contain deep carie lesions. The principal criterion for the indirect pulp cap is that the pulp must retain the ability to repair, and these two teeth serve as good examples of both indications and contraindications. The tooth on the left, or the primary molar, is contraindicated for the indirect pulp cap technique. Very probably, were you to attempt this technique, the child would be back at your office 2 days with a cellulitis in the left mandibular region. Signs to look for are as follows. In this tooth, you notice that the carious lesion seems to communicate directly with the pulpal tissue. This is suggestive that there is an open communication between the oral environment and the pulp tissue itself. The degree of inflammation present here would be overwhelming to the pulp and be irreversible. Conversely, looking at the first primary molar on the right side, you notice that there seems to be a solid layer of dentin between the carie lesion and the dental pulp. These are the first signs that you look for radiographically. Now, secondly, if you will look in the mesial pulp horn of the second primary molar, you notice diffuse calcifications. These calcifications are indicative that the degree of inflammation in the is rather severe and the now is depositing reparative dentin in a disorganized manner. This also is a symptom of severe inflammatory reaction existing in that pulp. In the first primary molar, you see that the pulp tissue overlying the carious lesion is relatively clear with no evidence of pulp stones or disorganized calcification going on. The third sign to look for is evidence of periapical inflammation, which of course would be indicative the inflammation has proceeded beyond the pulp and now involves the periodontal tissues. On the apex of the distal root of the second primary molar, you can see the beginning of a granuloma, whereas on the distal root of the first primary molar, the periodontal membrane seems to be as normal as you usually can find in primary teeth. The fourth sign that you must look for is subjective and must be elicited from the patient. Pain after eating or pain otherwise stimulated by the placement of food or drink in the mouth can occur in a normal pulp and be purely a response to the food penetrating deeply into the carious lesion and producing a proper response to normal structure. However, the child who reports spontaneous toothache when I go to bed at night or I wake up during the night with a toothache, or I was sitting in school and all of a sudden my tooth started hurting, is indicating that the pulp is undergoing a severe inflammatory process. Very probably necrosis has already begun in that pulp tissue. Sudden stimulated or spontaneous pain in a tooth is also a contraindication to the indirect pulp cap technique. This slide is a graphic model of the tooth selected for the indirect pulp cap. Dental caries has proceeded very close to the pulp tissue, but all subjective and objective signs indicate that the pulp tissue still has a capability to repair. This tooth has been selected for the indirect pulp cap technique. All caries must be removed from the lesion, with the exception of that last bit of overlying the pulpal tissue. The actual textbook description of this says that you remove all caries except that last bit, which, if it were to be removed, would result in a pulpal exposure. This is not a very good clinical guide to use until you have gained a great deal of clinical experience. For the present time, I would suggest that you plan on removing 75% of the caries and allow 25% to remain, but only that 20% that is in the base of the lesion directly overlying the dental pulp. It is absolutely imperative that all carious dentin be removed from marginal areas and that margins be established in sound dentin and enamel. This next step is to place a sterilizing agent directly in contact with the carious dentin that is permitted to remain in the tooth. Two materials may be used for this. Both have been described in the literature and apparently produce a similar response. Calcium hydroxide mixed with distilled water has been reported as successful in these situations. The pH of this material is extremely high and it becomes bactericidal in nature. We prefer the mix of zinc oxide and eugenol for this treatment bait. Eugenol in the solution is bactericidal and has an additional benefit of being palliative to the dental pulp under this lesion. It is easier to handle and easier to place than the calcium hydroxide paste. The objective of this material is to stop the carious activity, destroy what microorganisms are present, and permit the dental pulp to start healing. The entire key is then filled with a quick-set mixture of zinc oxide and eugenol. This can be accomplished by putting a drop of zinc acetate solution in your eugenol or dissolving 3 or 4 zinc acetate crystals in the eugenol prior to mixing it with the zinc oxide. Once you have obtained the mix, you have approximately 3 minutes of work time prior to the time this material sets. It is absolutely imperative that the margins be totally and completely sealed from salivary penetration. Leakage around the margins will permit saliva and new bacteria to enter the lesion and reactivate dental caries. The objective of this technique is to stop the caries attack at time for the pulp to heal itself. Following the placement of this material, it is wise to use articulating paper and clear this material from occlusion so that it does not fracture. Normally, in a clinical situation, you will place your indirect pulp caps during the first visit of the patient to it. Then, while doing other restorative work, you can observe these indirect pulp caps, making sure the material remains in place and that the margins remain sealed. This must be to remain for 6 to 8 weeks in order for reparative dentin to be deposited. This slide is from a clinical study here at the University of Texas in which the microscopic and radiographic results of the indirect pulp cap technique were tabulated. The tooth that was treated is a maxillary second primary molar. It was anesthetized, the rubber dam was placed, and all caries removed tooth with the exception of that last bit in the floor of the cavity. The 2 cements, zinc oxide and eugenol, and then zinc oxide with zinc acetate and eugenol were placed, and the tooth observed weekly for 8 weeks to ensure that the treatment filling was in place. At the end of 8 weeks, the patient returned, the rubber dam was again applied, all filling material and the remaining carious dentin were removed. The next slide shows the tooth after all material and carious dentin was removed. There was not a visible pulp exposure. Radiographically, you can see now a definite layer of dentin exists between the floor of the carious lesion and the roof of the pulp chamber. The reason one must return into the indirect pulp cap and definitely remove all carious dentin is that in many situations you will find a pulp exposure at this re-entry procedure. After the carious dentin has been removed and a direct communication into the pulp discovered, proceed to pulpotomy. If you did not discover the carious exposure underlying that final remaining carious dentin, the pulp could undergo a slow necrosis. This is one of the ground sections of a tooth that we did here at the University of Texas Dental Branch. Directly under the arrow, you see that the dentin underlying the chamber stains a little differently than the balance of the dentin in the tooth. This would indicate one time this pulp was very nearly exposed, but following the indirect pulp cap technique, reparative dentin was deposited by that pulpal tissue in an attempt to back away from that inflammation being produced by the carious lesion. Pulp has formed a new roof of reparative dentin. Conceptually, you can view the indirect pulp cap in the following way. In this microphotograph, caries is approaching from the right to the left. It is in the normal dentin tissue, but you see that reparative dentin is being deposited by the pulp. To the left of the reparative dentin is the pulpal tissue. Assume that dental caries is pushing that pulp at a rate, let's say, 100 miles an hour. The pulp has defensibility, backing away from the caries lesion by depositing reparative dentin, but only at a rate of 10 miles an hour. Eventually, the carious lesion will reach the pulp and produce a direct communication between the pulp and its external environment. In this micrograph, caries approached from the left side toward this pulp tissue. The indirect pulp cap was placed and the dental caries attack was, if not completely stopped, slowed down to a crawling place. This gives the pulp time now to back away from the inflammatory area by depositing reparative dentin. You can see it has done this in the pulp horn area of this tooth. Note in the upper right-hand corner of the slide, a small amount of reparative dentin that has been deposited beneath the non-infected dentin as opposed to the area under the caries attack. This technique is also valuable in young permanent molars. In the mandibular second bicoated in this radiograph, you notice the pulp does not have stones, the periodontal membrane structure is good, and there seems to be a layer of dentin between the carious lesion and the pulpal tissue. Because of an open apex of this developing tooth, it would be extremely difficult to do satisfactory root canal. If we can prevent pulpal exposure by utilizing an indirect pulp cap and give the time to deposit reparative dentin, we will have provided a good service for the patient. The indirect pulp cap procedure was performed in this 10-year-old child. At the end of the 8-week waiting, all treatment restorations and all caries dentin was removed from this bicuspid. There was no pulpal exposure. You can see an increased density in the dentin underlying the carious lesion, which is indicative that some revascularization has occurred in this dentin. Originally, it was thought that the utilization of calcium hydroxide as the treatment agent made available excessive calcium ions to be deposited in the dentin for this remineralization process. However, radioactive studies disprove this theory, and we now make the assumption that the increased calcific material that is deposited in the dentin during this period of time comes from the blood supply of the pulpal tissue itself. We have only a bite wing radiograph available after the placement of a gold inlay in that distal occlusal lesion. This was taken 1 year following the previous radiograph, and you can see that we still have no communication between the restoration and the pulpal tissue itself, or remineralized dentin is still present and the pulp appears normal. This is a mandibular first permanent molar that was treated with an indirect pulp cap using calcium hydroxide rather than zinc oxide and eugenol. In fact, who treated this tooth replaced some calcium hydroxide in the lesion after the caries were removed, as is evidenced by the radial area just beneath the restoration towards the distal. Calcium hydroxide is radiolucent. Immediately radiolucent area, see the remineralization that had occurred in the dentin, and it shows the area of reparative dentin that does exist between the old carious lesion and the roof of the pulp chamber. If hydroxide is placed in direct contact with pulpal tissue, this is the reaction that you can expect. These next few slides are taken from Zander's original publication in the Journal of Dentistry for Children in the early 1940s. The area represented by A is where the calcium hydroxide was placed in direct contact with the pulpal exposure. The area C is what is left of the pulp tissue that has been in contact with the calcium hydroxide. The area D shows a complete absence of tissue, and the area E we will be looking at in more detail later. Calcium hydroxide has a pH in excess of 12. It is extremely caustic when placed in contact with living tissue, resulting in an immediate violent necrosis of the tissue. This is what you're looking at here in the areas represented by letters C. However, an interesting reaction has occurred in Area E. Let's take a good look at it in the next slide. What is represented here that is coded as Area A and B is the area that in the previous slide was noted as Area E. If E, you may return to the previous slide for memory as to what you are looking at. What is happening in this pulpal tissue that in response to the violent reaction to the calcium hydroxide, the pulp tissue is rushing fibroblasts to the edge of the inflamed area in an attempt to wall off the noxious materials, attempting to move deep into the pulp and produce a generalized inflammation. This is described as walling off stage of the pulpal defense mechanism. You are looking at a concentration of nuclei of fibroblasts. This is the 2-week reaction to the placement of calcium hydroxide mixed with distilled water on normal pulp tissue in human teeth. Look to the next slide for the 4-week reaction. The calcium hydroxide was placed in the area noted as A. C represents what is left of the pulp that was devitalized by the extremely high pH of the calcium hydroxide. Area D corresponds to the wall of fibroblasts that you saw on the previous slide. However, note that directly under that wall is the beginning of deposition of some sort of calcific material. Now return to the next slide and look at the 4-week close-up microphotograph. You are now a layer of calcific material that was deposited just under that fibrous wall. Area C is pre-calcified material that is being deposited by the cells that you notice in layer D. These are fibroblasts that apparently are assuming a more odontoblastic shape, depositing calcific material and beginning to line up in a typical odontoblast arrangement. Now proceed to the next slide, which is a weak microscopic section. This is another normal primary tooth where A presents the area where the calcium hydroxide was placed. C is the area of necrotic pulp tissue that was destroyed by the calcium hydroxide. Is the remnant fibrin wall. E represents the area of an initially deposited calcific material, and F represents cells lined up in a typical odontoblastic fashion forming reparative type dentin. The G area is pulpal tissue that appears to be totally normal. The calcium hydroxide produces an extremely quick and violent death to the pulp tissue with which it comes into contact, but immediately the normal pulp rushes fibroblasts to the area, erects a fibrin wall, and then undifferentiated mesenchymal cells convert into odontoblasts to begin depositing a layer of reparative dentin that becomes a new roof to the pulp chamber. This was a rather startling publication, and immediately methods were found to utilize this in the treatment of children's teeth. There is one word of caution that I must place at this time. All of these microscopic sections are of teeth that had no restorations, no serious lesions, and no history of trauma. In other words, the pulpal tissue in the teeth in Zander's study normal pulp tissue. All of us doing pedodontics were experiencing difficulty in handling primary teeth with very large carious lesions and pulpal exposures. We started doing what is described as calcium hydroxide pulpotomy technique. After doing the technique, became very discouraged because failure rates of this treatment varied from 60 to 90% in most cases. You see here one of the typical failures following calcium hydroxide pulpotomy technique in a primary tooth. The tooth was completely destroyed with internal absorption. This immediately posed some problems. Was something wrong with the technique? Was the material at fault? Did we not do the technique correctly? Or was there something going on in the pulp tissue that we didn't know about? The technique was modified by many people, but it still resulted in a high failure rate. The consensus of opinion was that since a carious lesion had existed, the pulp was inflamed, and that we were not getting the same response from inflamed dental pulp that Zander found in their teeth with normal pulp tissue. In other words, the feeling was that pulp that has been inflamed by a carious process will not respond the way we expect in calcium hydroxide treatment. For this reason, today we have a very limited use of calcium hydroxide placed in direct contact with dental and primary teeth. It is utilized only on mechanical pulpal exposures. calcium hydroxide is placed in contact with primary tooth pulpal tissue only in pure and simple mechanical exposures. The technique is as follows. Once the determination of a mechanical exposure is made, a small amount of calcium hydroxide powder with distilled water into a firm piece is placed over the exposure site. In order to keep from forming this calcium hydroxide in the pulp chamber, it is suggested that for this you use a relatively thin mix of a quick-set zinc oxide and eugenol cement or one of the commercial cement bases that sets hard. The objective of this layer is to hold the calcium hydroxide in place and then serve as a barrier to the pressure that will be placed in this area during amalgam condensation. Since the calcium hydroxide produces a very violent pulpal reaction, we want to minimize the area of pulp destroyed by the calcium hydroxide. If the calcium hydroxide is forced into the pulp chamber, unnecessary pulpal tissue will be involved in the reaction. As soon as the intermediate layer of cement has set, the preparation is completed and the final restoration placed. There is no need to restore this tooth on a temporary basis, waiting to determine whether the reaction is favorable or not. If you selected your case carefully, the pulp tissue underlying the exposure site will react correctly to the technique. The reason for insisting that calcium hydroxide not be used on all exposures is that the pulpal tissue under carious exposure is not normal pulpal tissue and will not react correctly to the calcium hydroxide treatment. This situation will be discussed in the next videotape.